Well, good afternoon, everyone. Welcome to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence mark this territory on which we now gather. Just a reminder to please enter your questions in the chat at the end of the presentation. As well, please answer a brief survey that will be sent to you immediately after the presentation. This will let us know that you are present today. And finally, our speaker today is courtesy of the Division of Respirology, and I would like to invite our new Chief of Respirology at the MUHC, Dr. Martha Kaminska, to introduce our speaker. Thank you.
Thank you very much. So it's my great pleasure to introduce Dr. Sana Swaleh, who is an assistant professor, respirologist in our respiratory division of McGill at the MUHC. She completed her fellowship in adult cystic fibrosis at the University of Toronto, and her clinical and research interest as well as expertise focus on cystic fibrosis and non-CF bronchiectasis and nontuberculous mycobacterial infections. She has presented nationally and internationally on these topics, and she has publications in journals such as Journal of Cystic Fibrosis and is a highly valued member of our division. So she is going to tell us about being stuck in the airways, the sticky truth about bronchiectasis. Thank you, Sam.
All right. Thank you so much, Marta, and thank you for the kind introduction. Thank you again for allowing me to present today and really giving me the opportunity to talk about a topic that I'm quite passionate about, which is bronchiectasis. My talk is titled Stuck in the Airways, the Sticky Truth About Bronchiectasis, Chronic Infection, Inflammation, and the Evolving Landscape of Care. I'm just going to start with a point of clarification. So during this talk, I'm going to be talking about bronchiectasis, but more specifically, I'm referring to non-cystic fibrosis or non-CF bronchiectasis, which is considered largely a separate entity from bronchiectasis secondary to cystic fibrosis, CF, which is another big area of interest of mine. But nowadays, CF is much better understood. The pathogenesis is really well understood. There's quite different treatment modalities. It's really studied as a separate entity, and there are therapeutics that are approved just for CF. So in the context of this talk, when I'm talking about bronchiectasis, it's primarily non-CF bronchiectasis. And I have no relevant disclosures and no conflict of interest. So during this talk, what we're going to talk about is mainly the pathophysiology and epidemiology of bronchiectasis. I'm going to talk about the diverse causes, underlying etiologies, and some comorbidities that are associated with bronchiectasis, review current therapeutics, and also talk about emerging therapeutics. I'll also take this opportunity to talk about the model of care at the Bronchiectasis Clinic at MCI and talk about some research gaps and future exciting directions that are headed. So let's jump right into it. What is bronchiectasis? So a little bit of history is obligatory. So it was first described in 1819 by René Laennec, who is also credited as the inventor of the stethoscope. And this description is based on the observations he made on auscultation and autopsies of his patients at that time. This is a translated description of bronchiectasis that he first posited, which was that it is the dilatation of bronchi, which is only met with in cases of chronic mucus cathar. This single fact, coupled with what we know respecting the long continuance of mucus sputa in the spot where they have been secreted, enables us to conceive the mode in which the disease is formed. A temporary dilatation produced by voluminous sputum is rendered permanent by the constant and successive secretion. And so in simpler terms, it is the abnormal and permanent dilatation of bronchi. And to this day, this description is pretty apt in describing what bronchiectasis is. We have here in the center a diagram of an autopsied lung, where you can see these dilated airways, bronchiectasis, and this is from 1838. The main diagnosis, really, it's a radiographic diagnosis, and that's how the diagnosis of bronchiectasis is made, is that you see it on radiograph and really confirmed on CT chest. The main finding is that the bronchioles, they're accompanied always with the accompanying bronchial artery, and the inner airway diameter is equal or bigger than the accompanying artery, so a ratio of 1 or greater. So that's the classic finding, the most direct sign. There are other signs which we can see here, which is the lack of tapering of the airway, and also when airways are visible within the perimeter of the scan as well, within the perimeter, near the pleural perimeter, and that's another direct sign of bronchiectasis. There are some indirect signs also, like mucus plugging, for example, or mosaic attenuations and things like that can suggest bronchiectasis. So this is the radiographic definition, but the International Consensus Committee on Bronchiectasis does recommend presence of symptoms to make the clinical diagnosis. Symptoms being cough and sputum production, ideally most days of the week, and a history of exacerbations to make the clinical diagnosis of bronchiectasis. In terms of exacerbation, so they're defined as a deterioration in 3 or more symptoms. Symptoms being cough, sputum, dyspnea, sometimes hemoptysis, and so on, that last at least 48 hours and are accompanied by a change in treatment or management, and exclusion of other causes as well. Exacerbations are morbid events. About 16% of patients will not recover to baseline lung function 1 month post-exacerbation. Those who have 3 or more exacerbations per year have an increased hazard ratio for death, a hazard ratio of 2.03 for death as compared to non-exacerbators. And exacerbations that require hospital admission more than double the subsequent mortality risk. So we can see here that exacerbations, like I said, are morbid events. They're associated with increased mortality as well, and hence the importance of trying to prevent them and instituting therapy and recognizing disease early on and instituting therapy to try to prevent these morbid events. What leads to bronchiectasis? So the underlying pathophysiology. So this is a model that was called the Cole's vicious cycle. There is some initial injury or insult. It's not clear what the initial injury or insult is in a lot of the cases, but there is some initial insult or injury, and it varies from case to case. It varies depending on the underlying cause, and this will lead to an inflammatory response, usually a neutrophilic inflammatory response, which will then lead to airway destruction and distortion. It will then lead to production of of a lot of mucus, and there'll be impaired mucociliary function and mucociliary clearance due to that. So there's mucostasis. With the mucostasis, this impairs host defenses, and the impaired host defenses will promote a bacterial infection, increase the susceptibility to infection, and lead to chronic infection. With the infection, you have more inflammation. With more inflammation, you have more destruction. So really, this becomes this vicious cycle of disease. And nowadays, this Cole's vicious cycle has been more aptly renamed as the vicious vortex, because there is a better understanding that each of these components, so the ciliary dysfunction and epithelial dysfunction, the inflammation, the chronic infection, the lung destruction, all of these components, they're actually highly interconnected one to the other. Each step begets the next, but also each step can mutually reinforce other steps, part of this vicious vortex model as well. And so they're all very highly connected. And this model helps explain also why early treatment and early recognition is important, because if this vortex continues on for too long, there's going to be really irreversible lung damage that occurs and too much lung function that is lost. And then the therapeutics that we're going to install will not have as much benefits as early on before this vortex really sets into place. There are multiple different causes of bronchiectasis or underlying causes of bronchiectasis. So there are different conditions and disorders that are associated with it. There's this large European registry. It's called the MBARC, so the European Multicenter Bronchiectasis Audit and Research Collaboration. They have shown in about their cohort of 1,200 patients, in one of their studies of 1,200 patients, showed that the underlying cause was found in about 60% of patients. There was, though, 40% of their patients, despite exhaustive testing, no cause was found at all. And that's what we would call idiopathic bronchiectasis. And the most common cause of the known causes was post-infections. And certainly we see this trend worldwide as well. With infections like TB, post-TB bronchiectasis is quite common worldwide. The reason why trying to find underlying cause of disease is super important is because studies have found that in about 40% of cases, when an underlying cause is found, it can actually change management. So that's quite considerable. And so hunting and trying to find the underlying cause is a key feature of bronchiectasis care. So this is a non-exhaustive list. We have in the bottom idiopathic, post-infections, like we talked about. It's not just post-TB, but post-severe pneumonia, post-MRSA pneumonia. It can be complicated with lung destruction and bronchiectasis. Aspirations, particularly in our elderly patients, any type of immunodeficiency, humoral immunodeficiency, but any immunodeficiency can be associated with bronchiectasis as a complication. We have genetic causes like cystic fibrosis, alpha-1 antitrypsin deficiency, primary ciliary dyskinesia. There's inflammatory causes like allergic bronchopulmonary aspergillosis, or shortened to ABPA, which is an inflammatory condition. It's a hypersensitivity reaction to in the airways to the ubiquitous mold Aspergillus. And previously it was thought that you needed a predisposing condition of asthma or CF to develop ABPA, but now it's more and more recognized that anyone with bronchiectasis can really develop ABPA as well. And that's treated as separately, that's really treated more with steroids and sometimes with antifungal. It can also be associated with rheumatological conditions like connective tissue diseases in RA, it's described in Sjogren, and a whole slew of other rheumatological conditions. And it's also described as a known complication, pulmonary complication in inflammatory bowel disease. And importantly, in these two conditions, in rheumatological conditions and in GI conditions, it can often precede, even up to, there's like case reports of preceding up to 10 years, the development of the systemic disease as well through mechanisms that are poorly understood. And this is why also it's important for physicians in other disciplines to recognize bronchiectasis and to be able to appropriately refer them for assessment and management, because it could be a complication or a feature in other multisystemic diseases also. And then another common cause that's not featured in this table as a separate entity is nontuberculous mycobacteria, or shortened as NTM, which is ubiquitous. It's in our soil, it's in the water, and that is known as a cause of bronchiectasis. So that can cause bronchiectasis in predisposed individuals, predominantly people who have dysfunction of the CFTR protein, old women who have a thin phenotype as well, and they probably have some genetic underlying predisposition that is not fully well understood or well known. And that could be a complicating feature, but it can also be present in as a complication of bronchiectasis due to other causes. So it's a bit of always the chicken and the egg whenever we have a case of NTM infection. There's more than 200 different species known, but the most common ones here and more pathogenic ones are Mycobacterium avium and abscessus. So part of the bronchiectasis workup is also identifying if there is an NTM infection and if it's just a colonization or if it's an active infection. In terms of worldwide burden of disease and prevalence, so we don't have data from major regions of the world. So you can see on the map here, we don't have any significant data from Africa or all of South America, for example. But we do know in areas like China, about 1 to 1.5% of the population has a physician diagnosis of bronchiectasis that's made. In the United States, they use insurance-based claims to get a sense of the epidemiology, and we know that that has increased with time. So around 2005, it was 53 people out of 100,000, and in 2018, that's increased to over 700 in 100,000 people. And we've seen this trend globally, consistently an increase in prevalence. We see it in the UK, in Germany, and in many other countries as well. So there's a true increase in prevalence. Now, why is that? It's not fully known. Part of that is increased disease recognition. Part of that is increased use of CT scans and being able to actually see and capture the bronchiectasis for sure. But I don't think that's the full picture. There's also belief that there is an increase in the underlying causes of bronchiectasis. So for example, with climate change, we know that there's more and more NTM isolation in North America. There's studies out of UFT that have shown in the last decade and 2 decades, there have been increased NTM isolation as well. And we know NTM can lead to bronchiectasis. So that could be one explanation. With worsening climate change and pollution, it leads to more airway disease and more airway inflammation. And airway inflammation can lead to bronchiectasis. We know bronchiectasis can be a complicating feature of COPD and asthma too. So part of the explanation can be due to that too, but the overall, we don't know fully what explains the increase in prevalence. It is a disease more prevalent in women also. So in cohort studies, women accounted for about 51 to 68 of the proportion of the cohort, and it increases with age. The prevalence increases with age too. We do know that it's associated with increased mortality also. So in a prospective study out of Brazil of 120 patients, there was an 11% mortality rate at 3-year follow-up. There are cohorts from Europe that showed that there was between a range of 16 to 25% mortality rate at 4 to 5 year follow-up. And as you can imagine, it does pose economic burden on the healthcare system. And so we have data out of Germany that showed that the bronchiectatic patients accounted for more than 1/3 more expenditure of total healthcare costs compared to their matched controls. So it is a disease of significant burden. So if we talk about how to broach treatment and really the therapeutics of such a large and heterogeneous group of disease, for starters, of course, if an underlying cause is known, you're going to treat the underlying cause. So like we said about NTM infection, you would treat with antibiotics and NTM regimen of therapy. If someone's diagnosed with hypogammaglobulinemia, immunoglobulin replacement therapy will then be indicated. If someone has CFTR dysfunction with a targetable mutation, then you would treat them with CFTR mutation modulator therapy. So treating the underlying cause is important, but pretty universal. No matter what the underlying cause of the bronchiectasis is, there are still some key principles of therapies, which I'm going to discuss. And the goals of these therapies is to slow lung function decline and slow down progression. We want to prevent exacerbations. Like I just mentioned a few slides ago, it is quite a morbid event and associated with increased mortality. So that is a pretty important goal. And also crucially, reduce symptoms and improve quality of life. If you've seen patients with severe bronchiectasis, you know that their quality of life is quite diminished with really severe cough, copious sputum, severe dyspnea, and all sorts of problems that goes with that, like urinary incontinence and not able to function much either because of their debilitating load of their symptoms. There's importantly the non-pharmacological approach that is crucial. So patient education, super important, vaccination, nutritional status. But then when we get down to the pathophysiology, we want to target each component of this pathophysiological vortex model that we talked about. And that's important because it really requires a multimodal approach. Like we said in the vortex model, each step is highly interconnected to the next. So if you only targeted one portion of the treatment, let's say antibiotics, if we were only to give antibiotics, that would give some maybe modest improvement, but that would not be enough to halt disease progression. That would not be enough to halt this vortex of disease. And disease would still progress because the lung destruction and the inflammation is still sustained by other stimuli. So we really need to do a multimodal approach to try to break this cycle as much as possible. At the foundation, we're targeting the impaired mucociliary clearance, and that's going to be with chest physiotherapy. There's different modalities to it. I'm going to show in the next slide just a couple of examples of what to do. But the main goal of chest physiotherapy is really quite literally to help expectorate out the mucus and the sputum. The evidence of this is modest, but it is recommended in all the society guidelines on bronchiectasis. It is related, it has been shown to improve cough and reduce dyspnea as well. Exercise is an important part of the treatment plan, just in general for conditioning, but also can be associated with some improved mucociliary clearance. There's mucoactive treatments, namely inhaled nebulized treatment, like with hypertonic saline. There's been a small study that showed that improved FEV1 by a modest amount and led to improved quality of life and symptoms too. So that is part of our treatment arsenal as well, and that helps hydrate the secretion and make it easier to expectorate. And there's evidence for pulmonary rehab, decent evidence that showed increased exercise tolerance associated with that and some decrease in dyspnea too. For the chronic infection, there's inhaled therapeutics, which I'm going to get to in a couple of slides. But there's also then systemic treatment for an exacerbation. So oral antibiotics, IV antibiotics, and typically because of the bacterial burden in the lung, the society guidelines recommend 14 days of treatment for an exacerbation. As for the inflammation, currently the main treatment that addresses airway inflammation is macrolide. And so the macrolide acts as an immunomodulator in the airway. Has been shown that it reduces the pro-inflammatory cytokines in the airways. It diminishes the inflammatory mediator in the airways. It also acts to reduce quorum sensing of Pseudomonas and disrupt biofilm formation. So it can help in general with airway inflammation, but also in the context of the Pseudomonas infection as well. And it acts in a multitude of different ways in the airways. There is a meta-analysis of 3 RCTs that has shown that it does clearly reduce exacerbations and increase time to first exacerbation as well. So this is part of our key therapeutics for someone who frequently exacerbates. It is well tolerated. It's usually the regimen consists of azithromycin, 1 pill a day. We do need to monitor for ototoxicity, which is rare but has been described, and also monitor QTC on macrolide therapy. And the main big thing that we need to monitor is for NTM. So you want to make sure that the patient does not have NTM prior to starting macrolide or does not develop it during macrolide treatment, because that could lead to resistance. And another just important part is that none of these therapies are Health Canada approved or FDA approved or even European Medicines Agency approved for the treatment of bronchiectasis. So they're all being used pretty much off-label. None of them have been specifically approved for the bronchiectasis treatment. This is just different forms of airway clearance that we have, chest physiotherapy devices that we have. Here, the most common one that you might see is the Aerobica. That's the most commercially available one. It has an internal resistor and it helps with the ciliary beating and the expectoration. So coming back to chronic infection, the organism that is most often colonizing or chronically infecting the airways is really Pseudomonas, which in the airways, when it goes from acute infection to chronic infection, when it's exposed to different lung stressors, it changes its phenotype. It has all these pathoadaptive mechanisms that changes its phenotype. It really reduces its energy consumption. It has lots of virulence factors that help it evade eradication and help it evade antibiotic and resist antibiotics. It's hypermutable, like I said. It also is characterized by its mucoidy, which is due to an overproduction of alginate and gives it its robust biofilm that's also resistant to antibiotics. And so here is just a schema of what a mucoid phenotype of Pseudomonas looks like. You can see that here on the right, it has this shiny appearance as compared to the non-mucoid phenotype, and the mucoid phenotype, which is a lot more resistant to antibiotic. Chronic infection of Pseudomonas is a marker of disease severity in bronchiectasis. Studies have shown that it is associated with decreased survival as compared to individuals with bronchiectasis that don't have Pseudomonas. It's associated with more hospitalization, worse outcomes, increased symptoms. It's also associated with more rapid lung function deterioration, as you can see on the slide here on the left. So this is why the term chronic infection is preferred over colonization, because the term colonization gives this inaccurate assessment that this might be something benign, a benign process. And as you can see, a chronic infection with Pseudomonas is anything but benign. And so that's the preferred term. Studies have shown that really the best time to eradicate Pseudomonas is when it's first acquired. So first emergence of Pseudomonas at initial isolation. And then with time, when it becomes chronic, it's virtually impossible to completely eradicate the Pseudomonas. There's been some small studies done, small sample sizes, but they've pretty consistently shown that with varying different regimens of eradication therapy, but when there is eradication therapy that is instituted at first isolation, it leads to about 40% eradication at 12 months. So that's, again, the best time to do it. And then when the infection becomes chronic, it's virtually impossible. And so for chronic infection, there have been various different regimens that have been studied, and it's usually inhaled antibiotics, which are nebulized treatments. They're given, they take about 15 to 20 minutes to nebulize twice a day, depending on how good the compressor is. So it's a treatment burden, it's a therapy burden. It takes time out of patients' day, and this is something that we're asking them to do day in and day out. So it is quite a heavy treatment protocol. But different studies have shown that it is associated with decreased frequency of exacerbation, increased time to first exacerbation. It does decrease the Pseudomonas density in the sputum, and there has been trends to improved quality of life also. Important to know that when you dissect these different studies that were done, the patient population in these studies aren't always the most severe and aren't always the most symptomatic. And this doesn't always correlate or reflect to the patients that are seen in my specialized clinic, who are a lot more severe, a lot more symptomatic, and who anecdotally do derive clear symptomatic benefit when they're started on inhaled antibiotic. So now we're entering the era of a more precision medicine, and there has been a lot of effort made to try to identify more robust biomarkers for the treatment of bronchiectasis. So one key inflammatory biomarker that has been identified is really the neutrophilic inflammation. So the neutrophilic inflammation. So again, when there is an injury to the airway, when there is an infection, the neutrophilic response is part of the host defense. But in bronchiectasis, this response becomes really dysregulated and exaggerated. And so there's an overproduction, an excessive production of or release of neutrophil elastase and other neutrophil serine proteases. There's degranulation of the NET, the neutrophil extracellular trap. And there is, this leads to hyperactivity, which leads to, it's been associated with increased epithelial damage and tissue remodeling due to this excessive response. And it's also been associated with more lung function decline and associated with more exacerbation. So this has been really found to be one of the more robust biomarkers in the bronchiectatic airway. Other biomarkers in the multi-cohort studies out of Europe has been shown that about 25% of their patients had significant eosinophilic inflammation. So that becomes an interesting target to consider as well. We know that in the bronchiectatic airway, there is an overproduction of MUC5A also, and there is an overproduction of metalloproteinases as well. So those are all, potentially interesting biomarkers to consider. And which leads into one of the big trials that came out earlier this year in the New England Journal was the ASPEN trial. So this evaluated really a medication that would target neutrophilic inflammation. So neutrophil serine proteases, they're precursors they are transformed into the active enzyme in the bone marrow via the DPP1, so the dipeptidyl peptidase 1. And then they're recruited to the site of the active inflammation in the airways. So this trial, so it was a randomized double-blinded control trial, evaluated brensocatib, which is an oral DPP1 inhibitor. So it would inhibit that the change from precursor to enzyme of the neutrophil serine proteinases. It evaluated that compared to placebo. They evaluated 2 different doses, 10 milligram dose, 25 milligram dose, and the placebo, and it was a 52-week trial. So this is a cropped table. The actual table one was quite large. They were pretty evenly matched, but I just wanted to highlight a few important parts of this table to just highlight how the trial population can sometimes differ from the patient population that we will see in real life, and especially in a specialized quaternary center like at the Chest Institute, in the specialized bronchiectasis clinics, where I have some of the very severe patients. So first of all, it's a really good sample size. We have over 515 in each arm. But when you look more closely, we see at the bottom here in the bronchiectasis severity index, they all are, the mean is really a moderate severity rather than a really severe patient population, which is fine, but just a point of difference to note. Also not included here is the mean FEV1. So the mean FEV1 in each group is above 70%, which means that they have mild lung function impairment, which again will differ in what we see in real life in really severe bronchiectasis clinics. This is a patient population that does exacerbate a lot. So about 70% across all groups had 2 exacerbations, 30% had 3 or more. But then when you evaluate their therapeutics, only 20% are on macrolide therapy, or less than 20% rather on macrolide therapy across all groups, and only 7% are on inhaled therapy, while 35% in each group has Pseudomonas, which concords with what we saw in registry data too. About a third of patients would have Pseudomonas. So just by looking at this table, you can get the sense that this is a milder patient population, and they're not on the maximal therapy that I would see in my clinic, for example. And this might affect the generalizability of these findings to real-world practice. It did find, so the primary endpoint, which was exacerbations over the 52-week mark. So it did find that there was a benefit, statistically significant benefit at both doses. The brensocatib at 10 milligram had a rate ratio of 0.79 exacerbation versus placebo. And the 25 milligram had a rate ratio of 0.81 versus placebo. So there was clearly a benefit in the numbers of exacerbation compared to placebo. In terms of secondary endpoint, it took longer for first exacerbation. So that too was statistically significant. However, the finding that I think is most interesting is that at the higher dose, the 25 milligram dose, there was a statistically significantly less decline in FEV1 as compared to placebo or the 10 milligram one. So whereas the placebo had a lung function decline of 62 milliliters at the 1-year mark, the 25 milligram brensocatib had only 25 or 24 milliliter lung function decline. And that's most interesting because we're talking about maybe a therapeutic that can help preserve lung function. So that makes things quite interesting. And so after the publication of this trial, FDA approved both doses for the treatment of non-CF bronchiectasis. And this made a lot of media headlines too, because this is really the first medicine or first therapy that has been approved for the treatment of non-CF bronchiectasis. So that's quite major. It's not Health Canada approved yet, so it's not something that we can just actively prescribe in our clinics now. And it's really nice to have something else in our arsenal for the treatment of non-CF bronchiectasis, especially that this is an oral medication, so it doesn't have the same time burden as other nebulized treatment do, for example. It didn't have too many side effects. It didn't lead to too many treatment discontinuations. So the side effects that were described were, this was a study done in the era of COVID-19 and the height of the pandemic. So there was slightly more COVID-19 infection, nasopharyngitis, some cough, some headache associated with that. But really it didn't lead much to treatment discontinuation. So it was overall well tolerated. However, the part that is yet to be seen is really how will this translate to a more severe population who are already on maximal therapy? Are they going to also derive the same benefit with the addition of brensocatib? I hope so, but it will have to be seen in the real world. And then also more other interesting questions would be, if we add this, would we be able to start removing some of the more time-intensive therapeutics as well? So it's some interesting avenues to explore there. Okay, so if we bring it back home to the MUHC and the model of care here at the and really try to show you what we do here. So this is the Bronchiectasis Clinic that I started at the Chest Institute. And really my patients and I are super lucky and blessed to have a really dynamic team of allied healthcare professionals who are super motivated, passionate, and really care about the patients, really are devoted. And as you know, that makes all the difference. And so it starts with, the usual, a thorough history and physical exam, and really trying to dig at the bottom of trying to find the underlying cause. So we'll do an initial extensive workup, and it includes an appropriate patient looking for CFTR dysfunction, looking for autoimmune diseases and immunodeficiencies. A lot hinges also on patient education. So myself, but also a lot of the team members will spend a lot of time educating patients, patient empowerment. You need to have patient buy-in and for them to understand their disease and the rationale for the therapies and to help them commit so much time to doing all these labor-intensive therapies as well. Our specialized nurse spends a lot of time with the patients, again, educating them, but also teaching them how to do their various therapies, setting up resources in the community for them, being a resource person themselves, helping organize for home IV antibiotics whenever they have exacerbations. So they're really a key person for them. We have amazing physiotherapists and respiratory therapists that do a fantastic teaching, particularly for airway clearance. And so anecdotally, a lot of my patients really derive a benefit from having a teaching session with them. They find that it's high value, that it really benefited them, and they completely changed the way that they were doing things and how they were doing their airway clearance. So they found this extremely beneficial. Dietitian that helps with their nutritional status. And of course, lung function and regular chest imaging to monitor for disease progression, regular sputum, which is very important because we really want to monitor for Pseudomonas emergence. Like we discussed earlier, we want to catch the Pseudomonas early and try to eradicate it early if you got the opportunity to get it. But if you're not checking the sputum, you're never going to know. But also for NTM emergence as well. And also, I'm very lucky to benefit, and my patients are very lucky to benefit from a rich multidisciplinary collaboration. So I will often refer after initial workup, if everything has been pretty negative, to my colleagues, my really astute colleagues in immunology at the Immune Deficiency Treatment Center. And so they're going to do more extensive immune profiling, and they're going to do more extensive work for underlying causes of immunodeficiency as well. And then in appropriate patients, I will often refer them to my colleagues at the children's side at the Primary Ciliary Dyskinesia Clinic, spearheaded by Dr. Shapiro, where they'll do state-of-the-art diagnostic testing. They'll have a nasal NO machine. They also have a really rich longitudinal patient registry that is funded and that is supported by the PCD Foundation. And up until recently, they were also doing a whole genome sequencing via the NIH for cases of bronchiectasis of unknown cause. And I think a concrete example will help illustrate the potential of a specialized clinic like this to help patients. So this is a patient that was referred to me a little while ago, a 24-year-old gentleman who came in with a debilitating cough, copious sputum, a lot of dyspnea. He was diagnosed with over 20 pneumonias requiring IV treatments over the years. You can see here on his X-ray, he does have areas of perihilar bronchiectasis here, these lucencies that you see here. And he came in with very, very low lung function with an FEV1 of 28%. So we did, the usual, an extensive workup, extensive genetic panel, everything was negative. No evidence of cystic fibrosis. We referred him to the PCD clinic where our colleagues tested him for PCD, no evidence of primary ciliary dyskinesia. Our colleagues in the immunodeficiency clinic assessed his immune status and really could not find anything there to be contributing. He did meet criteria for ABPA. He had a very, very high IgE and a significant Aspergillus IgE as well. And his microbiology showed Pseudomonas with the mucoid phenotype. So then we employed really the multimodal approach to treatment, a lot of patient education, chest physiotherapy, started him on mucoactive agents as well. The ABPA was treated with steroids and antifungal treatments. He had a little bit of asthma, so we added on inhalers. And that wasn't enough. He was still having copious amount of sputum and still was quite symptomatic despite that. There was some improvement, but not optimal. So we added inhaled antibiotics as well to target the chronic Pseudomonas he had. And after institution of all these therapies, at follow-up, we see that his lung function doubled to 3 liters and 63%. Now, I'd like to say that all patients have such a robust benefit, but that's a lie. That's not true. This is one shining example, but really when people are referred to my clinic and they have a lung function of 28%, oftentimes there's already way too much lung destruction already there, and we'll do all of this work and all of this workup as well, but the benefit will be modest. And so when should you refer? Well, really anyone with bronchiectasis would benefit with at least an assessment and an evaluation, but more specifically young patients who might have underlying genetic disease like underlying cystic fibrosis that wasn't diagnosed, for example, but also they have a lifelong potential to potentially progress and deteriorate. And so you want to try to catch them early and institute treatment early. They might be heading for lung transplant, for example. So you really want to make sure that they're referred early. Anyone with frequent exacerbations or really severe exacerbations should ideally be referred. Anyone with lung function decline, worsening symptoms or quality of life, and anyone with radiographic progression. So what's next in the pipeline? So there are other treatments that are being considered. So there are other neutrophilic inflammatory agents that are being looked into, like the antagonism of the CXC chemokine receptor 2. What's the role of other immunomodulatory drugs, like, for example, anti-eosinophil therapy, anti-IL-5 therapy in eosinophilic inflammation? The data is not out on that yet. What about the role of microbiomes in different profiles and trying to understand their interactions? What about therapy to restore normal epithelial defense or improve epithelial defense? And also, the whole exciting role of whole exome sequencing and proteomics and really trying to get more precision medicine and targetable and better targets for patients. This here is a table of just all the different trials that are currently ongoing that are evaluating, again, different components of this vicious cycle. And with that, I will conclude. Thank you for your attention, and I'll take any questions.
Thank you so much for this very comprehensive review on this very important topic. We'll take questions. You can answer your questions in the chat. I'll start with the room. Are there any questions in the room? Yes, Martha. Okay.
Can you hear?
Yes, maybe just come forward.
Thank you so much, Sana. Good review. Lots of developments. I was wondering about the inhaled antibiotics, that you mentioned. And if you check the sputa regularly, you catch the Pseudomonas and you try to eradicate it. But sometimes patients haven't had their sputa checked regularly and they show up, they have an exacerbations and then we realize they have it. So, what do you do in those circumstances in terms of, trying to still eradicate it, or if they've had it in the past, like what's a delay that's reasonable? What do you try to do? And then I guess my sort of broader question with the inhaled antibiotics is what are your other indications in terms of sputum, symptoms,
Yeah, so great question. So there's no guideline-based answer to this, so it's a lot based on clinical expertise. But in general, if they're coming in with an exacerbation, you're going to treat them with systemic antibiotics. And part of the eradication protocol, I glazed over it briefly, but there are different protocols that have been described. And part of the eradication protocol is systemic treatment and trying 2 weeks of systemic treatment. So if they're coming in with an exacerbation anyways, you're starting with systemic treatment anyways. And then you're going to see them at follow-up and see if they're still symptomatic and what their sputum is growing. A lot of the times, again, it's chronic Pseudomonas. They're still going to be growing chronic Pseudomonas. So it's worth attempting then inhaled antibiotics. At least, the guidelines will say at least for 3 months, just to see if they'll derive any benefit from it. So that was the first part of the question. And then the second part of the question was...
So if you're not trying to eradicate it, do you ever use it, just for symptoms?
Yes, absolutely. So if we're not trying to eradicate it, then we do use inhaled antibiotics for chronic suppression. There is, like I said, different regimens that have been described across the world. They use different antibiotics. Here it's mostly inhaled tobramycin. But there is a benefit that has been shown, even in studies with inhaled tobramycin, some studies that have shown decreased frequency of exacerbation, increased time to first exacerbation, improved at least trends for quality of life. And when you analyze those studies, it does seem like the results are more robust in patients who have higher density of sputum, of bacteria in the sputum. So when someone is very, very symptomatic, like a lot of sputum, a lot of cough, they might not be necessarily exacerbating so much, but they're very symptomatic and they have Pseudomonas, I will attempt inhaled antibiotic. And a lot of the times it does help.
Okay, Basil, do you want to take the microphone?
Yeah, thank you. So great talk, Sana. So, there's always this sort of conceptual yin and yang between, treating the infection on the one hand and then the use of these anti-inflammatory therapies that theoretically suppress the immune system and could potentially, find yourself working at cross purposes. So I'm just wondering, do you have a sort of an algorithm or an approach where, through the combination of whatever biomarkers of inflammation versus what you're finding on the microbiology that kind of guides you to say, well, in this patient, we should be focusing more on suppressing the inflammation versus, trying to treat infection. It seems like oftentimes, patients just have the book thrown at them and they're kind of on everything. But I'm just wondering, in terms of what you were mentioning, in terms of the emergence of personalized therapy approaches, how you see that.
Yeah, that's a great question. So there's no specific algorithm for sure. When I'm seeing patients, we're starting pretty much one therapy at a time. Eventually, they'll end up with the whole book thrown at them, as you said, but we're starting with one therapy at a time, and we're trying to see with clues and markers if we can figure out what's more predominant. Sometimes it's obvious that it's more an inflammatory process going on. They have really high eosinophils, they're wheezing a lot, they have a remote history of maybe asthma, they're coughing, but there's not much sputum, and that helps figure out, okay, there might be sometimes an infection going on there, but right now it's really more the inflammation that's predominant versus an infection where they'll have a lot more copious sputum, and the sputum will really have a high density of bacteria. So sometimes we use that to tease out which is the more predominant driver of disease. But like I mentioned with the multimodal vortex model, in my experience, and also what's been described, is that we'll try to target one thing, because again, we'll do one thing at a time. So in a case of someone with really high eosinophils, we'll start like on anti-IL-5 therapy, but quickly on follow-up, we'll see that the inflammation's better, they're wheezing less, their eosinophils are better, but now they're coughing a lot of sputum. On chest x-ray, we're seeing a lot more mucus plug. And you get the sense that, okay, no, there's the infection that's worsened now. And so oftentimes we do have to treat pretty much each component. So we're not yet at the point where we can just treat one component and that will just halt the vortex.
Mark, I'll take a question from the chat and then I'm coming to you. Okay, is dietary restriction focused on weight loss?
Yeah, so not weight loss. A lot of our patients actually have a very low BMI, partly due because of the chronic infection. And also it's well known with low lung function, our calorie needs, there's a nice model based on the CF studies as well, that when the lower your lung function, the higher your basal metabolic needs. And so a lot of these patients are quite cachectic. And so the dietary interventions actually focus on increasing calorie intake and improving nutritional status.
Fantastic, Mark.
Yeah, thanks very much. Great presentation overview. I wonder if you could give us a sense of the burden of illness. So at any sort of given day, how many patients are admitted with bronchiectasis exacerbations at the MUHC? How big is your clinic? Are you the only game in the Ruiz on the island of Montreal?
Okay, great question. All right, so how many patients are admitted? I don't know those statistics for here. In terms of my clinic, it is growing, but right now it's over 100 patients with bronchiectasis. And again, a lot of them are more on the severe side. It is growing. We are also in our division growing as well. So there is more interest in non-CF bronchiectasis also. But yeah, right now, I'm not sure about the SHIM side. I think they do have a bronchiectasis clinic on the SHIM side as well. But this is not common to every hospital.
So there's a question from family medicine about cost debate in our healthcare. What is the mean cost of care of your typical patient, and how is there a way to keep things simple, I guess, in cost management?
Yeah, so the cost of care of typical patient, like I quoted from the German study, we know that in age match, at least in Germany, which is almost a similar healthcare model as here, it was 1/3 more than their match control. So it is costly. And in terms of how can we keep investigation and management simple, it depends case by case, right? So if we have a really young patient, like the example that I showed that has a FEV1 of 28%, you have to do everything. You really need to get to the bottom of it and you have to do everything. And again, when we tried treatment approach and we did one thing at a time, it was not sufficient. And so we really needed to throw the whole treatment out them. If you have someone with really, really mild disease, again, back to the beginning of my talk, if they just have radiographic bronchiectasis, really no symptoms at all, you don't necessarily, and you would need to follow them to make sure there's no disease progression, but you don't necessarily need to throw everything at them either. But whenever in doubt, it's always better to refer.
On that point, you follow disease progression with high resolution CTs?
So initially, we do get a high resolution CT to just get a better sense of what's going on with the lung, and certain patterns are suggestive of certain diseases as well. So that can be helpful. But then afterwards, we get routine chest x-rays on very easily at our clinic. So usually we follow with routine chest x-rays, and then if there's any deterioration and I need more information, then I'll get a CT, but it's not routine.
That's it. There's a question about hypertonic saline. Is it useful for bronchiectasis?
It's part of the treatment. So that's one of the mucoactive treatment. Of course, before you want to make sure that they don't have a bronchospasm to it. So you want to get a test dose and make sure that they'll be able to tolerate it. The evidence for that was modest. It led to some improvement in FEV1, some improvement in symptoms, but not everyone tolerates it, and also not everyone needs it.
And what about segmental lung resection?
Yeah, so I didn't talk about that, but that's a good point. So for certain patients, if they have really localized disease and they're very symptomatic from localized disease, even in cases of, let's say, massive hemoptysis that's really localized in one specific bronchiectatic abnormal area, then local segmental resection would be indicated.
Fantastic. Are there, yes, go ahead.
Thanks. So my question was just, do you see antimicrobial resistance as a negative prognostic factor among your patients, and how does that play into sort of stratifying patients and their management? Thank you.
Yeah, good question. So we do see antimicrobial resistance, as you well know, as well, particularly with our patients with Pseudomonas who are exacerbating, unfortunately, a lot. And so each exacerbation, they're just so symptomatic. There's a significant lung function decline. We have to treat with systemic antibiotics. And then, as you know better than I do, that the more systemic antibiotics they're exposed to, the more and more resistant they become. So we definitely see that. We don't see it so much with inhaled antibiotics, and there have been studies on that as well. And usually with inhaled antibiotics, like for tobramycin, we're giving it at a dose inhaled that's so much above the MIC that we would test in the lab. And so we'd see less of that profile of resistance. And also we usually go with the approach of doing a few weeks on therapy, a few weeks off therapy that helps prevent the development of resistance. That's more for chronic suppressive therapy. For macrolids, there's been extensive studies that haven't shown emergence of resistance. Again, the only caveat is we want to make sure they don't have NTM, but it doesn't treat Pseudomonas anyway, so we don't see resistance due to that. But with Pseudomonas and recurrent exacerbation, we do see the emergence, and that's a bad sign.
Yeah, Mark?
Do you think it's underdiagnosed? Do you think we're missing a lot, given the overall symptoms very generalized?
Yeah.
From COPD exacerbations of general medical points, etc.
Yeah, great. So the question was about underdiagnosing bronchiectasis, and I do think that's probably being underdiagnosed. Like you said, first of all, we see the global trends. There is a clear rise in prevalence as well. And then the symptoms, like you mentioned, are vague: cough, sputum, dyspnea. So a lot of the times they can be ignored for or easily explained by other conditions, like just pure simple COPD or even asthma, and it can be underdiagnosed due to that, for sure.
Any tips? Correctly diagnosed?
So what if someone has chronic cough and sputum production in particular, even the society guidelines do recommend that it's worth getting at least a chest x-ray, and if the chest x-ray is equivocal, a CT scan to just confirm the diagnosis.
Okay, thank you very much. Oh, yes, one more question. Go ahead.
We have time. Well, just on the epidemiology, it certainly seems like people are like we're seeing more, and perhaps, you mentioned that there's increasing for different reasons, maybe something improved survival from underlying sort of causes, aging population. But in terms of mortality, like what are the causes? Is it chronic respiratory sort of failure, acute exacerbation, and how much hemoptysis, you certainly see a lot of that. How much is just kind of like wasting,
Yeah, so the main cause of mortality that at least found in the large cohort studies were respiratory failure, usually believed to be precipitated by infection. There are stuff like hemoptysis, but massive hemoptysis is still not the most common cause. And of course, there's usually competing issues as well, like a longstanding smoking history. So there's cardiovascular disease too, but the primary cause is respiratory failure.
Fantastic. Well, thank you so much for this really excellent, great overview of this topic. Thank you for that. Thanks everyone for your participation in the question period. And I wish everyone a great afternoon. Thank you.
Thank you.
Bye-bye.